Welcome to this medicine masterclass in which we will be discussing the management of a pneumothorax. A pneumothorax is a collection of gas in the pleural space that results in a variable amount of lung collapse on the affected side. Spontaneous pneumothoraces occur in the absence of any trauma to the chest wall. Primary pneumothoraces occur in people with no underlying lung pathology. Secondary spontaneous pneumothoraces occur in patients with pre-existing lung parenchymal or pleural pathology, so patients with asthma, COPD, emphysema, sarcoidosis, connective tissue diseases such as Ehlers-Danlos syndrome or cystic fibrosis, or interstitial lung disease all increase the possibility of a secondary pneumothorax. Now, if the pneumothorax is large and the patient will present with chest pain, they would appear tachycardic, tachypneic, they would have reduced breath sounds on the affected side, reduced chest expansion on the affected side, and hyperresonance on percussion on the affected side. They would have decreased tactile and vocal fremitus on the affected side. The radiograph is the most useful investigation, particularly in a non-tension pneumothorax. In a tension pneumothorax, which is an emergency, the patient should undergo needle decompression. Now, in 2010, the British Thoracic Society proposed a method for quantifying a pneumothorax size on the PA chest radiograph by measuring the distance from the lung edge to the thoracic wall at the level of the hilum. And a distance of less than 2 centimeters are classified as small pneumothoraces. In a non-tension pneumothorax, a chest radiograph is an accessible and very useful investigation in the management of a chest radiograph. The British Thoracic Society proposed a method for quantifying the size of a pneumothorax on a PA radiograph by measuring the distance from the lung edge to the thoracic wall at the level of the hilum. A distance of less than 2 centimeters is classified as a small pneumothorax. The management of pneumothoraces is based on the BTS pleural disease guidelines. The first step is to determine whether the pneumothorax is considered primary or secondary. A secondary pneumothorax is considered in patients who have a significant smoking history or evidence of underlying lung disease on clinical examination or are over 50 years old. And a primary pneumothorax is in younger patients aged less than 50 years old, an absence of a significant smoking history with no evidence of lung disease on examination or chest radiograph. In patients with a primary pneumothorax, the size is determined, and if the size is greater than 2 centimeters or the patient is breathless, they should undergo needle aspiration using a 16 to 18 gauge cannula, aiming to aspirate less than 2.5 liters. If the aspiration is successful and subsequently the pneumothorax is less than 2 centimeters and the breathing has improved, the patient can be discharged and reviewed in an outpatient setting in 2 to 4 weeks. If, however, despite needle aspiration, the patient remains breathless or the pneumothorax is more than 2 centimeters, a chest drain should be cited. A primary pneumothorax, which is small, less than 2 centimeters, in an asymptomatic patient, can be discharged and followed up in 2 to 4 weeks in an outpatient setting. Patients with secondary pneumothoraces, irrespective of size, will require a degree of observation. So a patient who has a pneumothorax that's secondary more than 2 centimeters or is breathless should directly undergo chest drain insertion. If, however, the secondary pneumothorax is less than 2 centimeters, i.e. 1 to 2 centimeters, they should undergo needle aspiration. And if, as a result of the needle aspiration, the size reduces to less than 1 centimeter, they should then be observed from that point onwards. But if the size remains above 1 centimeter, a chest drain should be inserted. In patients with a secondary pneumothorax that's less than 2 centimeters and less than 1 centimeter, then they can be admitted for at least 24 hours of observation. So this guideline, which also suggests that if there's any evidence of bilateral or hemodynamic compromise should directly proceed to chest drain, gives us a very good understanding that primary pneumothoraces can potentially be discharged in small asymptomatic patients, but secondary pneumothoraces, irrespective of their size, warrant a degree of admission, oxygen, and observation. Thank you for attending this medicine masterclass.